right, so I'm going to talk about arrhythmias today. And for those that don't know me, I'm Davey, former critical care fellow, interloper into this community. And thanks for having me be here. Was certainly very grateful for all the education that you guys offered me during last year. So hopefully we can do some education today. This is meant to be open, so if you have questions, thoughts, comments, certainly open to them. All right, so I have no disclosures. So the objectives today: refresh some diagnosis and treatment of arrhythmias, and then offer a safe space to discuss real-life cases, conundrums, and arrhythmia care. The outline for today's, we're going to talk about some epidemiology, some mechanisms, arrhythmia and Palm Clinic. I wanted to make sure we get some Palm Clinic shout-outs, not just the critical care. Unstable arrhythmias, tachycardia, bradycardia, and then we'll wrap up. So I wanted to start this with a case, just to get us all centered in the right space, and that an 85-year-old no known past medical history presents with flank pain, fever for 2 days. I'll keep this really simple. Vital signs: tachycardic, hypotensive, and febrile. Exam is altered and warm. As a leukocytosis, AKI, metabolic acidosis, and a lactate of 5 on the labs. This is the EKG. I'll spare the fellows in the room so far, but this is AFib with RVR. We've got our heart rate right around 150 as noted before. And so I think this is a good centering case that we have patients that come in for illnesses and they're very sick in the ICU and they develop arrhythmias, many questions that can come from this. So let's talk epidemiology. So in thinking about this talk, I wanted to make sure that we thought about how often arrhythmias happen in all of the different settings. So in COPD, certainly one example, it's, the overarching theme is that it's common. So a national inpatient sample of 1.3 million patients with COPD on home oxygen, almost 20% of them had concurrent AFib. And that a sample of patients with Holter monitors and concurrent diagnosis of COPD were much more likely to have AFib and SVT, sustained VT, compared to patients without COPD. There's plenty of contributing factors that make this overlap possible, and unfortunately possible. Comorbid conditions that they share between COPD and arrhythmias: hypoxemia, autonomic dysfunction, medications that you guys are all too familiar with. And then AFib and arrhythmias and COPD offer significantly worse prognosis. So patients with AFib had increased risk of death, mechanical ventilation, non-invasive ventilation, and stroke, as well as increased costs and length of stay for patients with COPD. So let's talk about arrhythmias in the ICU. So again, very common. One multi-center registry identified that an incidence of about 12 to 17% of sustained arrhythmias in the ICU population. And this is a general ICU population, not just the CICU. And that these were associated with sicker patients, patients with sepsis and SIRS, hypoxemia, elevated CVP, acute myocardial infarctions, obviously, and then acute kidney injuries. This is also true for, they also have a significantly poor prognosis. In-hospital mortality broken down in that same cohort based on no arrhythmias or certain arrhythmias. And you can see that the no arrhythmia group has a improved mortality compared to the groups that have the concurrent arrhythmias. Now, the take-home message for this is that I want you to kind of go away from this and know the fact that you already know that arrhythmias in the ICU as well as in pulmonary clinic are common and they can be significantly harmful. Now, past epidemiology, I want to think about mechanism. Now, this is a graphic that I like to think about when tackling ICU problems, as well as arrhythmias, is thinking about kind of who's in charge. And, is the leader of the illness the heart? And is that kind of pushing the shopping cart that has all the other injured organs? Or is it the bacteria that is then causing the heart to have problems, or, many times the lungs? This is a graphic from circulation from this past year that I have modified a little bit that I think really highlights that point. In that when patients in the ICU or when they have severe COPD or asthma, there are multiple insults that can cause the heart to be stressed and dysfunctional. So, bacteria, viruses, inflammatory responses, altered autonomic nervous system, systemic illnesses, all lead into that. I've added in the medication component of this because we, cause proarrhythmia with norepinephrine, epinephrine, dopamine all the time. So the take-home message from this part is, continuing to remember that arrhythmias are common and harmful, but also to keep in mind the proarrhythmic impact of illness. Now let's talk about arrhythmias in Pulm Clinic. This is the first EKG that I'll ask for some help in interpreting. Does anybody want to offer a rhythm diagnosis for this EKG? MAT. So great answer. So we're going to focus on the rhythm strip down at the bottom. And I've highlighted here the P waves with these arrows, and each colored arrow is a distinct P wave morphology. And so you have multiple P waves here, 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 and here that look very different. And so this is a multifocal atrial tachycardia EKG. Now, for these patients, they're usually somewhere in the 100 to 150 range. They have an irregular rhythm. And the technical definition is that they have 3 or more distinct P wave morphologies. Now, the important part of this potentially is that it's associated with elderly and COPD. I have seen a handful of cases of MAT in my early career, and unfortunately, none of them have been associated with COPD. They've all just been associated with people, that are sick. But in a large multi-center cohort, they showed that about 55% of patients with MAT had concurrent COPD. So there's an association, but it's not perfect. Now, for MAT, rhythm control recommendations are pretty rare. In all the cases I've ever taken care of, the MAT is not hemodynamically significant, nor is really clinically significant as much as a marker of other illness. And that the rhythm control recommendations would be for worsening ischemia, heart failure, perfusion issues. But again, I've never seen a case of that. For calcium channel blockers, theoretically, verapamil has the best data for MAT rate control, but the data is not great. And so I think, honestly, you could use rate control of any type. Diltiazem for calcium channel blocker or metoprolol. But I wanted to highlight, just take an aside to talk about calcium channel blockers and beta blockers really quick. Because calcium channel blockers have a theoretical risk. I guess it's actually not theoretical. It's a physiologically guided risk of inhibition of hypoxic pulmonary vasoconstriction, leading to VQ mismatch. With the vasodilation of those poorly ventilated areas, there is some physiologic data backing this, as well as some kind of very basic clinical data. But I don't think this is a very strong link, in that the use of calcium channel blockers in patients with COPDs and right heart failure is actually associated with decreased mortality. And that there's a New England Journal review from 2020, and in their opinion, the calcium channel blocker use is a first-line option for management of hypertension in patients with significant COPD. Now, with that said, beta blockers, a little bit of a different story. I wanted to first highlight this kind of fun fact that I learned recently, that beta blockers are becoming the venture capital, an interesting venture capital tool for success. Helps jumpstart a career. You take one pill before your presentation. I did not take one today, but maybe I should have. But just something interesting that you can get over the counter, or not over the counter, but through a relatively shady service. But beta blocker. So we'll break this down. Beta 1 blockade is the cardioselective aspect of this, decreases heart rate and cardiac output. And then beta 2 blockade leads to bronchoconstriction. You guys know this well, the beta 2 aspect of this very well. Now, there's cardioselective beta blockers that at low doses are predominantly focused on beta 1 blockade, but at higher doses are a little bit less specific. These include atenolol, bisoprolol, metoprolol, and esmolol. There are non-selective beta blockers as well that have more beta 2 activity. Those include propranolol, carvedilol, sotalol, and labetalol. Now, for beta blockers, multiple studies have shown that in patients with COPD, that beta blockers are significantly underutilized. So one study showed that for patients with HFrEF and COPD, which is a class 1 indication for a beta blocker, 39% of patients with COPD had a beta blocker at discharge. And this was a odds ratio of 0.51 compared to patients that did not have COPD. So certainly a really impactful part of this. And that beta 1 selective agents in clinical studies have shown that they decrease heart rates and that there's no change in exacerbating respiratory symptoms and no change in adverse respiratory events. Now, while COPD pathology is not primarily based on bronchospasm, certainly there's lots of overlap that exists. And so recommendations to pick cardioselective beta blockers and start low and work your way up. those are very reasonable. And I should mention that this particular study was in patients with COPD without active wheezing or bronchoconstriction. And that the introduction of beta blockers can decrease the risk of death with the cardiac indication. Now, for beta blockers in asthma, the data is a little bit more muddy, and the kind of physiology is a little bit more muddy, because certainly there's a significant bronchoconstriction component to this. In one clinical database, introducing beta blockers into patients with asthma, significant asthma, there was a physiologic change that physiologic both and clinical change that was pretty significant. 11% of patients had worsened symptoms, and 20% had a reduction in their response to beta agonism. Now, for selective beta blockers, this was a little bit attenuated, certainly, with worsened symptoms in only about 3% of patients. I certainly have given lots of beta blockers in patients with asthma, and certainly some have responses where they feel like their symptoms are getting worse and others do not. I don't see the level of asthma that you guys do, but the guideline for this is to think about choosing a cardioselective beta blocker, start low and move your way up. This is to highlight that difference between cardioselective and non-cardioselective. On the bottom, you have the odds ratio or the risk ratio for an asthma exacerbation. The introduction of labetalol or infusion of propranolol is a pretty significant increase, whereas things like bisoprolol, atenolol, metoprolol, relatively less on that scale. And so choosing cardioselective beta blockers and going low, or starting low and going slow as you work your way up, is the current recommendations. Now, 3 take-home messages that we've built up so far. Arrhythmias are common and harmful. Keep in mind that the proarrhythmic impact of illness, and then COPD and asthma and calcium channel blockers and beta blockers have a fraught relationship, but start low and go slow because they certainly can be really helpful. All right, now let's move to unstable arrhythmias. Now, for an unstable arrhythmia starting point, the first most important thing beyond checking if the scene is safe is to assess the stability of the patient and keep in mind who's in charge. So we go back to this, there's always something to keep in the back of your head. Which mechanism is really kind of driving the ship here. But once you assess stability, the first aspect of stability is assessing a pulse. If you don't have a pulse, then you work your way down a very specific circulation algorithm for starting CPR. If you do, then working down the similar but different tachycardia with the pulse algorithm. And I think it's helpful when presented with these arrhythmias is to really focus on the management first and then kind of think more creatively about the diagnostics. But for those patients that are unstable, working into the CPR algorithm is really important. And there's a couple of points here that are focused on arrhythmias that I wanted to highlight based on the 2025 update on this CPR guidelines. Now, obviously, we all know that CPR is very important. There's a new song. I don't know if you guys have seen this Taylor Swift person, but she has a new song that's very important. Could think about in your hands-only CPR. But after starting that, there's a few aspects of the care of patients that don't have a pulse that I think is really important to mention. The first thing is when thinking about defibrillator and the intensity at which you defibrillate somebody, there are 2 randomized control trials looking at the amount of joules that you should use. And these 2 trials compare fixed doses of either 150 or 200 joules versus an escalating dose, where you start at 200 and then work up to 300 on your next shock and then 360 on your final shock, or kind of progressive shocks after that. They didn't show a difference in survival, but the increased shock joules did identify that there was a significantly increased rate of conversion. With this, they moved it to a 2B recommendation that if your defibrillator has energy to do subsequent shots, to consider that. This is predominantly in the outpatient setting. In the inpatient setting, I'm kind of a 360 or bust kind of guy, but that isn't necessarily what the guidelines will tell you, but I don't think there's anything wrong with that. The only disadvantage of 360 is it can cause some local skin irritation and burning, but I think that's probably the least of your worries in these certain situations. The other thing that I wanted to mention was pad placement and double sequential shocks. So biphasic shocks are highly effective in going from ventricular fibrillation or pulseless VT into a normal rhythm. Occurs in roughly 75 to 80% of shocks in a cardiac arrest setting. But the term shock resistant or shock refractory is commonly used. And I think many times it's used inappropriately. For those 20% of patients that get shocked and nothing changes, they're still in VT or VF, that is shock refractory. Then there's plenty of other patients, about 80% of those patients, that then return into VT or VF after converting to a normal sinus rhythm. And so you transition from VT to, maybe a sinus rhythm, and then while you're doing compressions, you turn back into VT. And that is not necessarily shock resistant or shock refractory, and you should think about those patients a little bit differently. But theoretically, this is something that you can do, is to think creatively about both pad placement and the consideration of double sequential shock. So the standard is anterior lateral. In the cardioversion lab up in the EP lab, they do anterior posterior. During a cardiac arrest situation, that's obviously much harder to do, to get to somebody's back while they're doing chest compressions. But theoretically, a vector change is just highlighting that anterior posterior. And then double sequential shock is where you hook up two different defibrillator devices in two different pad situations, and you shock them basically at the same time, but basically right after each other. There's a trial, the DOSE VF trial, which looked at this and identified that for patients with the vector change or anterior posterior and then double sequential shocks, that they had a significant increase in their survival to hospital discharge. Now, I wanted to highlight a couple of caveats to this, is that if you analyze the treatment that the patients actually received and not what they were randomized to, there was no benefit in the primary outcome. And in the secondary analysis, again, the only group that benefited was the small group that after you shocked them, they didn't return into a normal rhythm. So it was just that 20-ish% of patients that after you shock them, they're still in that abnormal rhythm. Now, patients that are elderly have abnormal hearts, as well as patients that are significantly overweight, are patients to consider these types of strategies for. But with that, the AHA and ILCOR did not necessarily feel like this trial was high enough to really give a good recommendation. And so they gave a 2B recommendation that you can consider vector change or double sequential shock after 3 or more consecutive shocks, but that it's not been well established. So a little hand wavy there. And then a couple of other things to mention: electrical pacing for patients with PEA arrest or asystolic arrest is not recommended. And I think the real moral of the story here is that it takes your eye off the ball of all the rest of the important things that you're doing during CPR. And then the role of antiarrhythmics was talked about. There are a couple of trials, from the 90s and early 2000s that highlighted amiodarone did increase the survival to hospital admission, but didn't necessarily change the survival to hospital discharge. And then there was a follow-up, the ROC ALPS trial from, when was this, 2016, that compared amio versus placebo, lido versus placebo, and then amio versus lido, and again identified that there was no survival to discharge benefit, but survival to hospital admission benefit for both amio and lido, and that there was no difference between the two. So with this, they gave it a 2B recommendation for amio or lido, either one, in patients with VF or pulseless VT that are unresponsive to defibrillation. A couple of other points: steroids there's a couple of other agents you could theoretically use. I have never used these. I don't know if anybody else has, but beta blockers, beryllium, procainamide, or sotalol in the setting of pulseless VT or VF with an uncertain benefit. Steroids have conflicting trial data and are listed as an uncertain benefit. And then the routine use of calcium, bicarb, and magnesium is also listed as, or is now listed as a class 3 indication, is not recommended. Now, they certainly have uses in torsades as well as hyperkalemia, but not in routine use. All right, we've talked about a few different things within this pulseless algorithm that are arrhythmia related. The take-homes would be using amio or lido is recommended, kind of, or lido. Monophasic shock at 360 or a biphasic shock, I personally use 360, but theoretically could start at 200 and work your way up. And then there's not really a great role for other routine use of things like calcium or steroids. Now, with that said, if you have a pulse, there is its own algorithm here, and I wanted to highlight the top part of this algorithm. So to assess the appropriateness of heart rate for the clinical condition, this again gets to that point of who's pushing the cart. Typically, you're at 150 or greater, but certainly plenty of patients have variability here. And then the next pink category, I think, is a really important part of this. And I think all three bolded words are important, that this is a persistent tachyarrhythmia that is causing the issue. So the persistent part of this is if you have a patient that has an abnormal heart rhythm that's going in and out, your treatment strategy is going to be very different as if they're stuck in that heart rhythm. If they're flipping in and out constantly, then doing a cardioversion is not going to be necessarily very helpful for them. Because you're just going to be right back in the same situation you were before. And then causing, I think, again, thinking in your head about that picture of who's pushing the cart is really important. So if you have an arrhythmia where it's causing hypotension, then thinking about synchronized cardioversion is really important. If you have time while you're hooking things up and you have a narrow complex, you can certainly consider giving adenosine. And then the next step is thinking about a wide QRS rhythm. And this is really kind of attacking, is this VT or not? If it is a wide QRS rhythm, then considering adenosine while you're getting everything else ready, antiarrhythmic infusions, and then certainly thinking through this with cardiology, as well as clarifying the diagnosis. Is this VT or is this an SVT with aberrancy or something else? And then if none of those things are met, then you move down into the bottom category. You have a narrow complex, you have an arrhythmia that is not causing any alterations that are concerning. And so try some vagal maneuvers, try adenosine, try calcium channel blockers or beta blockers if able, consider expert consultation, and then consider arrhythmic infusions as well. Now, with that said, how are arrhythmias treated in the ICU? We're going to talk about how arrhythmias are treated in the ICU. We'll talk about rate control, vasopressors, some alternative strategies, and then diagnosis of SVT, and how adenosine fits into that. So for treatment overall, a multi-center registry identified the treatment of tachycardias in ICU, and this is the percent breakdown. I thought this was relatively helpful in thinking about. I feel like the amiodarone percentage of 51% is probably a little dramatic, but still all the usual suspects are on this list. But I think, honestly, the first thing to think about when treating these tachyarrhythmias, and you get down to that bottom algorithm and think about rate control, is do you need to? Can you tolerate that heart rate of 140? Is that something that is actually beneficial for the patient? And so really considering that and not thinking just about the number, but thinking about how that fits into the patient context. In the outpatient setting, we shoot for an AFib heart rate less than 110. That's based on the RACE2 trial. That had 0 ICU patients in it. And so, is this a number that we should shoot for? I don't know. And there's no good data on this. There's no rate control studies in an ICU setting. And certainly calcium channel blockers and beta blockers can cause harm. I think we've all seen cases where patients got too much or too little, and mainly causing issues and harm, cardiogenic shock, all those types of things. And then my overall recommendation for rate control is to target permissive tachycardia and to understand that the treatment of that number might actually be worse than the condition that you're treating. Do you have a number? I would say a little bit of it's vibes based. And I think it's age based as well. So if you have a 20-year-old that you don't have many options for and they're going 150, that's probably okay. If you have an 89-year-old going 150 and you haven't tried much, then you can try some things. I think that it also, my heart rate goal kind of increases based on how hard I have to try to get it lower. And so if I've tried beta blockers and now they're on pressors, and I've tried digoxin and I've tried other things and it's still high, then I might have to wash my hands of kind of crossing that line. But there's not really a great number. All right. And then the other thing I wanted to mention is, along those same lines of adding beta blockers into this, is that, you are adding medications that are potentially beta agonists like norepinephrine and epinephrine. And that if you add in a concurrent beta blocker, which I've certainly seen a few times, not necessarily judging the success or the recommendation of using that, but that is something to consider. I'm not sure that I would, because it really kind of transitions to a different physiologic milieu. But this gets to the same point of thinking about pressor alternatives. So if you have a patient that's in sepsis, that has septic shock and is on a decent dose of norepinephrine, and their heart rate is 160 in AFib, I think about, adding in the vasopressin earlier. Think about transitioning to phenylephrine, understanding that that is not, your pressor of choice in these situations, but think about considering an alternative. Switching away from those beta agonists as well as dopamine, which has a tremendous arrhythmic burden, to other things like vasopressin and phenylephrine. This is not guidelines based. This is more anecdotal and just trying things out. The good thing is if it works, then you have a quick on and off. If it doesn't work, you also can go back to what your strategy was pretty quickly. Digoxin can be really helpful in these situations. It's relatively easy to use, works through increasing your vagal tone. You give an IV load for this. It starts working over 4-ish hours. In my experience, there are patients that are added onto this in the ICU or on the floor, and over the next 8-ish hours, their heart rate goes down 5, 10, 15 beats per minute, and you start to notice it working. There are other patients that this doesn't change anything at all. And those are the patients that, continuing the digoxin probably doesn't have much use for. But acknowledging that digoxin is proarrhythmic, and so making sure your electrolytes are replete, and that the long-term use is associated with increased mortality, which I could give a whole nother talk about that particular set of data, but it's not wonderful in that setting. But you would be potentially using it in the acute setting. In that dosing in AKI and CKD as well as CRRT can be done just very carefully. And so whenever I'm dosing digoxin, I make sure to talk to the CCU pharmacist. I know Mike and Megan are wonderful. I think they also talk to the CCU pharmacist when doing this, but certainly a really important part of that. And then I have just one word, ivabradine, with a question mark. I'm not going to put any data here because it actually doesn't make much sense to me. But ivabradine has been used a little bit more in the CCU, and we've had some success with this. We're going to publish a case series on this. But physiologically, ivabradine should work just on the sinus node, so it doesn't really make sense why it should work in AFib in these patients. But keep your eyes peeled for that in the future. I would not recommend using this without crazy CCU attending supervision. And then other antiarrhythmics. So for short-term use, amiodarone, procainamide is commonly used in Europe for cardioversions, and lidocaine for ventricular arrhythmias. But considering the need for anticoagulation. Strokes are bad. I don't have to tell you guys that. In a survey of patients after PCI, they weighed stroke as the worst outcome that could possibly happen, even above death, which in comparison to providers put death number one. And so I think, that has made an impact on me, and that same result has been seen in many other forms, not just the PCI realm. And so thinking about the risk of stroke is important, but I can't tell you what the risk is. Nobody studied that. There's no CHADS-VASc for sick ICU patients that have platelets of 5 after their bone marrow transplant. And so I think it's just a conversation with patients, family, and the team to make sure that everybody's on the same page. It's actually easiest when you don't have a choice. You have to, they're hemodynamically unstable, and you can make that decision and feel better about it. But it really comes into play when you have those patients that it's a little unclear if the benefit outweighs the risk. And that it's important to note, this is an important part of this, is that left atrial stunning that comes from a direct cardioversion or amiodarone can really last for 30 days afterwards. And so this isn't just the moment in time, even if you could look in their left atrial appendage at the time, but really can last for the month afterwards. And so this is an important consideration for those patients. All right. We added a couple of treatment tips for this, is to consider just being okay going fast. Start with metope, but if they're hypotensive but try to avoid it if they're hypotensive or on pressors. Consider switch to norepinephrine, to vasopressin or phenylephrine if clinically reasonable. And then digoxin's an option, but it does have some risks. And then for those patients, if it's AFib or flutter, then and need to be anticoagulation, and can be anticoagulation, do amiodarone or trial cardioversion. And the good thing about the amiodarone aspect of this is, again, this is short term. You just got to get over the next few days type of thing. You're not running into those risks, the ILD risks from amiodarone, the eye risks from amiodarone over time. So from a take-home message standpoint, arrhythmias are common and harmful. Let's keep in mind the proarrhythmic nature of impact of illness. For COPD and calcium channel blockers and beta blockers, start low and go slow. You can use amiodarone or lidocaine in the arrest situation. Consider permissive tachycardia, and then think creatively when you run into those problems. All right. We've got about 10 more minutes. We'll talk about tachycardia and then bradycardia. So I think one important point about this and kind of centering back is really understanding the stability of the patient. These EKGs of, wide complex tachycardias can be very intimidating, and that there's, complex algorithms to figure out what the exact rhythm is. But I'd make an argument that most of the time it doesn't matter. And that most of the time, especially in the ICU setting, you're going to treat an SVT with aberrancy or a VT the exact same way. And you're going to kind of pick up the pieces and can take time to diagnose it afterwards. Whenever I'm thinking about arrhythmias and tachycardia in the ICU, the first thing I do is look at the tele and the graphic trends specifically. And there's two different ways these tachycardias can present. I'll highlight this yellow line, and that on the y-axis we have heart rate, and on the x-axis we have time. And I'll make it real simple for you. There's two different ways that it can present. One is the kind of slow uptick and then slow downtick in heart rhythm. And that is more consistent with a sinus tachycardia or a bleeding event, or it can be in setting of AFib, chronic AFib, but something has changed that has made them sicker over time. And then the alternative is a quick onset arrhythmia. This is your atrial flutters, your SVTs, where you're at a heart rate of 50 and then it jumps up to 150 very, very quickly. This gives you a help in the diagnosis, but also the intensity of the arrhythmia. And then when I'm thinking about diagnosis, I bring up this algorithm in my head every time. And it's separating the tachycardias into wide and narrow, separating those into regular versus irregular, and then bringing up the diagnosis for those particular aspects. Now, if you take this into kind of a big picture, there's 12 diagnoses on here, and it's hard to separate them. But if you use this algorithm of narrow versus wide and irregular versus irregular, then you can get to a point where you're thinking about either one or two things, or in the case of a regular narrow complex, just a few things. All right, let's run through a couple cases. Does anyone have any ideas of what this tachycardia is? I'll give a shout out to Max, who correctly identified MAT in the chat earlier. Thank you, Max. Yeah, so great. So this is atrial tachycardia, or ectopic atrial tachycardia. Now, the important parts for this is it's a narrow complex tachycardia. It's a narrow complex tachycardia, and it's regular. And so we work to, there's 6 different things it could be. Now, Rashawn, why did you say it was ATAC and not sinus tac? Yeah. So if you look in lead 2, you have these nice scoopy inverted P waves, which is not the normal P wave. The normal P wave, as Bhushan correctly identified, is upright in 2 and inverted in AVR, and that was not what we saw. And so that's an ectopic atrial tachycardia. How about this one? Say it a little louder. Yeah, so it's a great point and great answer. Thanks, Jesse. So we're narrow complex, irregular tachycardia. So we're at AFib, multifocal to atrial tachycardia, or A flutter with variable block. Now, I have intentionally moved this to cover up V1, which can be intentionally confusing. And if you look at every other lead, the baseline is pretty wobbly. If you look at V1, then it looks like flutter. It looks like it's got that coordinated rhythm to it. If you cover up V1, which is the lead that is closest to the heart in the left atrial appendage, then then everything else looks like AFib. And so what I would encourage you to do is, when looking at patients that have either AFib or A flutter, cover up V1, because it can be deceiving. And so that this is actually just coarse AFib. So if you cover up V1, all the rest of these leads are pretty consistent with AFib, and that the left atrial appendage can be deceiving in V1 in many EKGs. All right. Jesse did a great job at identifying this EKG from before. You get some really nice flutter waves here. So narrow complex.
Can you just say a little bit more about that? Like, what is deceiving? Like, if flutter waves exist anywhere, doesn't that define?
Yeah. So the left atrial appendage many times can have its own coordinated electrical system that, it's, the left and right atrium are, big structures. The left atrium appendage kind of sits off to one side and is closest represented by V1. And the kind of the inflow into the left atrial appendage can still be a relatively coordinated aspect. And so that the left atrial appendage is kind of beating roughly once is, about 300. And there's a great video, which unfortunately was taken off of Twitter, of somebody doing an open heart surgery and the patient's in AFib, and you can see the whole rest of the atrium is just kind of jiggling. And then the left atrial appendage is doing something that looks more controlled. Unfortunately, I don't have that video anymore, but maybe try to imagine in your head of this left atrium that doesn't do well, but then there's this little piece of it that is kind of having a little bit more coordinated activity.
It's theologically true, but just not representative of what the whole atrium.
Yeah. So the easiest way to think about this is if you're ever concerned AFib flutter, just cover up V1 because it will always confuse you. All right. A flutter here where you've got a narrow complex regular rhythm, nice flutter waves in 2/3 and AVF. And then how about this one? For the sake of time, this is an SVT. And the reason I say that is it's narrow, it's regular, but then you don't see many other clues here. So it's hard to tell. So what I would say is that this falls into the category of hand wavy SVT. And it could be any of these things, any of the 6 things on the left. And so in these cases, adenosine can be really helpful. So this patient was given adenosine, and then the flutter waves popped out. And so adenosine can be really helpful in patients with AFib, flutter, ATAC, and sinus tachycardia because they will get rid of your P or your QRSs for a little bit of time, and then you can start to see those P waves, either flutter waves or nothing in the case of fib, ATAC or sinus tachycardia. And
for me, I see that maybe the QRS complex, so I'd be nervous about giving this person adenosine because I'm worried about WW.
Mm-hmm. Yeah, so giving adenosine in a patient with known WPW is not recommended because that will facilitate their accessory pathway. I would say that every time I've ever been asked about looking at an EKG for WPW for this particular instance, it has never been consistent with WPW. WPW is a diagnosis that you have to have a wide QRS, like the conduction of it will lead to a wide QRS, and you'll have potentially, hopefully, a baseline EKG where you can start to interrogate that. If you look in V3, for example, it looks like maybe there's some like upsloping that starts a little early. The problem with this is that that's just where the flutter wave is kind of hitting. And so you're misinterpreting a wider QRS and kind of an upsloping for that flutter wave. So I think, if you're ever concerned, don't give it and, try other things. But what I would say is that it's a pretty rare circumstance, and you'd have to have a relatively high suspicion anyway. And this one is a narrow complex, and so you should be okay. All right, and then for AVNRT, AVRT, or junctional tachycardia, those all require the AV node to be used. And so if you give adenosine, then there'll be a pause, and then you'll restart your sinus node. Well, hopefully, you'll restart your sinus node. Vagal maneuvers can also be very effective. Hit or miss, everybody chooses their own. The learning points for this is regular versus irregular is important, and thinking about that algorithm, considering vagal maneuvers and adenosine, and thinking, kind of keeping this diagnostic algorithm in your head. Now for SVT versus VT, when you have a wide complex tachycardia, thinking about this as similarly irregular versus regular. I think the difference between polymorphic VT and an irregular SVT with aberrancy is a little bit easier to figure out. But for VT versus SVT, it can be really confusing. And so the most important part of this teaching to highlight is that this is all about pretest probability. So 80% of patients with wide complex VT or tachycardia is VT. And so you go into that room and you're thinking to yourself, it's probably VT. I need to convince myself of otherwise. And that if they have a history of MI, heart failure, angina, or structural heart disease, that positive predictive value is up to 95%. So you really have to change your mind. If this is a 25-year-old with no coronary disease and coming in with urosepsis, then it's a different story. But if they have a history of an MI and heart failure with reduced ejection fraction, then this is likely VT. And that the symptoms have a poor diagnostic value. This is a common misconception by clinicians, is that VT in 25 to 50% of patients have no cerebral symptoms. And that there's plenty of other characteristics, but you have to have a high suspicion for this. So some of the most kind of easiest to use aspects of considering VT versus SVT is AV dissociation, where you see a P wave marching through. This is unfortunately not super common, but theoretically could be. And then the presence of fusion and capture beats. All three of these factors are indicative of VT. Fusion and capture beats is that you have that P wave that's marching through, and then it strikes gold and hits the normal conduction system just at the right time. And so then you have a normal looking beat in the case of a capture beat, or you have kind of this pseudo-normal looking beat in the case of a fusion beat. And again, that's diagnostic of VT. Otherwise, I pull this up all the time. This is something that is very easy to use when you have time. If you're in VT and the patient's unstable, it doesn't matter if they have SVT or resistant variancy, you're still going to shock them. You're still going to treat them with amiodarone. But if you have a little bit more time going to these websites, there's lots of great algorithms to take a look at. Not to memorize, but to take a look at. And so here's a great one that you could use those algorithms on. You don't see any fusion capture beats or AV dissociation, so this one's a little unclear. This one is a little bit less unclear. It's pretty wonky. This is somebody that walking into the room, you wouldn't need to necessarily look through as much as this looks really, really abnormal. But highlighting that the difference between these two EKGs, SVT versus VT, can be really difficult. This one actually ended up being an SVT. So, that's hard to differentiate. So using those techniques can be really helpful. But I wanted to highlight that even though this is confusing and hard, that treatment is the same. So aggressive treatment of unstable arrhythmias, regardless of diagnosis. And if it is stable, then you have time to work through those diagnoses and think. And so SVT versus VT, remember the pretest probability, remember important features, treat the unstable ones aggressively, and then for the stable ones, you have some time to work through them. And then we've added number 7 on here, that pretest probability in working through algorithmically for tachycardia is important. All right, one quick note on bradycardia. Pauses for patients with AFib, or excuse me, for OSA. So OSA is associated with AFib, both recurrence, presence, lots of issues with AFib. And once it's treated, the AFib can certainly get better. OSA is also associated with sinus pauses. This is something that can be pretty dramatic. They can have 5-10 second pauses overnight while they're sleeping. This is vaguely mediated. About 22% of OSA patients in a sleep apnea plus Holter monitor study had pauses or bradycardia. But importantly, that this is not felt to be an indication for a pacemaker. That when they're awake, if they're not having pauses, then they don't meet criteria for a pacemaker. And that treatment of their OSA or treatment of their obesity, diuresis, all those types of things can make those things better. There is an algorithm for bradycardia with the pulses or with the pulse that I'll skip over, but highlights atropine, dopamine, and epinephrine are our best friends. Isoproterenol is a great agent that can be used in these circumstances, but every time I've ever tried to use it at the bedside, it has taken many hours to get, and so it's not necessarily clinically relevant for the ICU. And then TVPs, heart blocks that do not have a stable escape rhythm. There's plenty of patients that have complete heart block that are on the floor on the cardiology service waiting their pacemaker because they have a nice stable heart rhythm. The other thing to point out here is a concerning history. If they're fainting at home or have other issues, then that would be an indication for TVP and close monitoring. Pauses is certainly a big part of this. 3-second pauses if they're in sinus rhythm. 6-second pauses if they're flipping between AFib and normal sinus rhythm are the kind of cutoff for getting a pacemaker. But if it's only happening overnight in your OSA patient, then there's no cutoff there. Well, theoretically, 30 seconds would be too long. And then overdrive pacing is a common indication for TVP for somebody that is having issues with torsades. All right, talked about a lot of stuff. I think we're right on time. I wanted to highlight the last learning point of bradycardia. You can defer pacemakers in patients with OSA that are having sleeping sinus pauses. But really wanted to highlight that arrhythmias, they're common and harmful. Please keep in mind the proarrhythmic impact of illness, that COPD and asthma have a fraught relationship with calcium channel blockers and beta blockers, but certainly there's good indication for. And so start low and go slow. Amio or lidocaine in cardiac arrest. Consider permissive tachycardia, thinking creatively about your arrhythmia patients in the ICU, and then really thinking about the pretest probability for patients with tachycardia. Getting back to our case, we had a person that came in with flank pain, fever of 2 days. They were tachycardic, hypotensive, lactate of 5, AFib with RVR in that setting. And my take-home message for thinking about this particular case is, arrhythmias are common and harmful. To keep in mind the proarrhythmic impact of illness, in this case, potential urosepsis of some flavor, considering the permissive tachycardia while you treat the underlying illness. And then for this person, thinking creatively about your pressor choice is an option. And that's the end. Any questions, thoughts?
How do you navigate when the stable, unstable binary becomes a little blurry? I feel like so often we have patients where it feels like their pressure requirement increases some with SVT, but we don't necessarily shock all of them. Sometimes we try a lot of these rate controller antiarrhythmic strategies first.
Yeah, I think that's a great question. And there's no perfect answer. I think it's really a case-by-case basis. There are some patients that go into an arrhythmia and nothing changes at all. And I think those are the patients that it's a little easier. Then there's other patients that they get really, really sick and, acutely hypotensive, or their lactate, skyrockets. And those patients, again, is pretty clear. The where to draw the line in those indeterminate cases where, they're escalating pressors and then they go into AFib and now they're even, still escalating pressors, it's hard. And I think, balancing that and kind of thinking through, is the treatment of this arrhythmia going to be helpful for them? I think, it's a case-by-case basis and there's no perfect answer for it. Max has raised his hand.
I have a question. This is Angela, one of the ICU fellows at Sparrow in Lansing. Regards new onset of AFib in ICU, mainly in secondary and sepsis issues like urosepsis, new onset AFib. Do we need to anticoagulate those patients if it's a new onset or paroxysmal AFib, secondary to sepsis and or dehydration?
Yeah, it's a great question. I think I have an extra slide here. So AFib in the ICU is pretty common. This is a very similar theme to before. The stat that I wanted to highlight from before is that for AFib and sepsis, the new onset AFib happens in 6 to 7% of patients, and that about 55% of those patients have AFib in the future. So what I would say is if a patient, in my perspective, again, this is opinion-based and not based on any Chad's VASC recommendations or ICU population, is that if you have a patient that can be anticoagulated and is in a stable spot and has new onset AFib, is that I personally would recommend initiation of anticoagulation. But there's certainly plenty of patients that is not an easily done task, and that there's plenty of risk with anticoagulation that comes along. And so, again, it's a little bit of a case-by-case basis, but there is a risk of them having AFib in the future. And if you decide to do a rhythm controlling strategy, such as a cardioversion, that they'll need anticoagulation moving forward. And again, most of this is opinion-based. And so, I'll acknowledge that this is my opinion. I'm sure that there's plenty of different strategies of people, what they have done kind of outside of this. And so certainly interested in perspectives if other people disagree.
Just to follow up on this, my name is Christian from Sparrow as well. If you have a patient that ends up requiring a antiarrhythmic such as amiodarone, and you then switch to orals, and then you are looking towards getting this patient out of the hospital or looking towards eventual discharge, but this was basically an AFib that was put on due to sepsis, would you continue amiodarone long-standing for that patient, or would you just have them as like a follow-up outpatient with their cardiology team, or set them up with cardiology overall?
Yeah, great question. My personal stance is to use the amiodarone as a short-term tool. And I think we've all seen cases where a medication gets started in the hospital and then it gets forgotten about or continued for much longer than thought about. If the patient is in a stable situation, then my personal practice is to have them stop the amiodarone. Usually that's after a load, whether it's 6 or 10 grams, depending on what you believe in that nature. But after the amiodarone load, then you stop it. They're on the floor. They're off pressors. They look good. Take them off and understand that 55% of these patients are likely to go back into AFib, and so continuing their anticoagulation, get them set up with a cardiologist as an outpatient.
Along those lines, so do all of these patients, because I'm fairly confident most of our patients who go into AFib briefly in the ICU don't follow up with cardiology. Like, should we be, and maybe hospital medicine does this, and I'm just not aware, but I don't think so from the people I see in the post-ICU clinic. Should they all be getting, long-term cardiac monitoring to see if they're doing this? Or should we set them up with cardiology every single time it feels like you're already?
Yeah, there's definitely a long wait list for cardiology at the University of Michigan. What I would recommend is that many of these patients will have AFib in the future, and that this is likely the first time that they, some of these patients, the reason that they're going into AFib is because of the proarrhythmic milieu, but a lot of these patients have AFib at home and they've never noticed, and this is the first time they've ever had a monitor on. And so that having them follow up for further AFib care is very reasonable from my perspective. There are plenty of referrals that come from hospital medicine for these types of things, but many of these patients get lost and never come in.
Davey, I was just going to ask, I feel like when people are coming in, we'll say septic shock to the ICU, we often, and they're on beta blocker chronically, whether for AFib or for heart failure, we'll often hold it in that time. And I'm never quite sure when to restart that medication necessarily, kind of after their shock. I've run into a number of times where patients will start becoming tachycardic, a couple days after their shock has resolved, and I'll realize we haven't stopped their beta blocker. They don't have anything else going on that's clear, and trying to restart it at that time. Is there any kind of guidance you have on kind of restarting rate control agents after resolution of shock?
Yeah, great question, Max. I would say that there's no perfect guidance on this. And in the CCU, we think about this really hard because a lot of the patients have indications for beta blockers that then they go into cardiogenic shock for one reason or another. And then restarting that is fraught with, are we going to send them back into cardiogenic shock? For patients that are unstable and, urosepsis on epinephrine, and then they're transitioned off of those things, shock has resolved, they're moving their way to the floor. Restarting beta blocker in those patients is very reasonable, especially if they have normal cardiac function and are not at risk for going back into kind of at high risk for going back into cardiogenic shock or going into cardiogenic shock. And so I think, when the shock is resolved, it's a good time to start thinking about that. If, their blood pressure hasn't fully resolved and they're, still looking like they're not ready for the floor, then, assessing that stability time point is certainly a personalized decision. But I would say, as soon as you feel comfortable. Well, thank you all for having me. This was a great time.